ये हमारी जो टीम है उसकी पहली शुरुआत है। मैं हिंदी में बोलूंगा, मुझे अच्छी लगती है। और ये हम लोगों ने कुछ प्लान किया है। मैं बड़ा भाग्यशाली हूँ कि ये जो मेरे साथ ध्रुव है, ये बहुत ही होशियार और बड़ा डायनेमिक आदमी है, वेगवान है इनसे। और नए नए इसके पास बहुत आइडियाज हैं। और मैं तो उसके साथ हूँ, ही सवाल ही नहीं है। हम लोगों ने प्लान किया, बहुत छोटे से मैं बता देता हूँ। हम लोगों ने सोचा है कि हर महीने जो मीटिंग होती है, दैट मीटिंग विल बी फॉर 6 months, इट विल बी डन बाय इंटास, एंड फॉर 6 months इट विल बी डन बाय सन, फ्रॉम जैन टू जून, and from then June to December. So this is how we bifurcate surgically the year between two forms. And we were not spending our money, our corpus funds, we were not spending at all, which is a bad thing to do, because then we can be caught by IT and we can be heavily penalty can be there. We may have to pay taxes to our nose in that date. So we have to spend money from our corpus, and obviously our good friends will sponsor those in retro guide, they will give that amount back. So there's a continuous flow of academic activities and expenditure. So this is what we are going to do. In June, we plan a national conference of Nagpur. That is Dr. Tawari, GM Tawari's oration at Dubai, Goa. दुबई नेक्स्ट टाइम दुबई। सो इस बार गोवा में सोचा है हमने, अगर दोनों कंपनियों को हम रिक्वेस्ट करेंगे कि वो प्लीज इसको स्पॉन्सर करें, एकेडमिक एक्टिविटी है। तो यही है। और 4 अपडेट करने वाले हैं हम, 2 न्यूरोलॉजी के, 2 न्यूरो सर्जरी के, हर 3-3 महीने में। और बाकी जो मंथली जो मीटिंग चलती है वो ऐसी चलती रहेंगी। तो ये जो है, ये न्यूरो सर्जिकल अपडेट है। नेक्स्ट विल बी न्यूरोलॉजी अपडेट, एंड अक्टूबर में अगेन देयर विल बी अपडेट। सो वी विल गो अल्टरनेट, न्यूरोलॉजी न्यूरो सर्जरी, न्यूरोलॉजी न्यूरो सर्जरी, दैट वे। थैंक यू वेरी मच।
So thank you very, very much, Lokendra Singh sir, for being the guiding light. I think most of his ideas after his experience of so many years have been trying to implement it this year. And I'm very thankful that all the members have had a very positive and constructive outlook during this year, which can be seen that they're now dropping in within 15 minutes of the time, which usually is not the case. So we are very happy, and we'll start the discussion. More people are expected to join in, and without much ado, we are very thankful, first of all, to our chief guest and speaker today, Dr. Amit Dhakoji sir. A round of applause for him for coming all the way from Pune, taking out time from his hectic schedule, doing a couple of surgeries in the morning, and then sparing time for a talk. So, brief introduction of Dr. Dhakoji. I mean, most of you know him. He is the head of Department of Neurosurgery at Manipal Hospital, Pune. He's after his MCH, he's done a fellowship in cerebrovascular surgery, but his special work interests lie in epilepsy surgery, which we have all seen here in Nagpur. Apart from that, aneurysm, skull-based surgery, and awake surgeries. He has an experience of 13 years. He's an alumnus of the prestigious Sri Chitra Institute, Trivandrum. He has trained at KEM, and then he has GMC Nagpur as he's an alumnus of GMC Nagpur, and he worked in one of the premier institutes of Nagpur, SIMS, and where he could showcase his exceptional talent in epilepsy surgery. So he has trained at Cleveland Clinic, Ohio, in advanced epilepsy surgery program, and he has a keen interest in microvascular anastomosis also. So he has completed more than 300 epilepsy surgeries, which in itself deserves a special round of applause for such a great contribution to epilepsy surgery, because we know how difficult it can be to manage these patients. And without wasting much time, I would like to invite Dr. Dhakoji sir to present his topic today, which is the management of low-grade glioma.
Thank you. Thank you, Dr. Dhruv, and I'm grateful to Nagpur Neuro Society for giving me this opportunity and honor. And it's always a pride and privilege to come back to your home ground and present in front of my esteemed colleagues.
Just a brief interruption, sir. I would like to invite our chairpersons, Dr. Amrit Bansod please, Dr. Amrit and Dr. Iratwar sir. So they are here, so we have an informal society here, so we are not worried so much. But thank you so much for agreeing to chair the session today. And if there are any questions or anything, please sir, take it.
Yeah, thank you, Dhruv. And good evening, all. Yes, this is okay. That's good. The tradition was started last year will continue. And I'm happy that the Nagpur Neuro Society's the dynamic leadership has been handed over to the most dynamic Dr. Nagpur Singh sir and Guru Batra. So, and he has already added his new ideas and energies at burst. So I think without wasting much time, please. So today we are going to discuss a very common topic, that is low-grade gliomas. All of us encounter in our practice as neurologists as well as neurosurgeons. And things have dramatically changed now in the management. Even I used to conserve low-grade gliomas around 7-8 years back and keep them on radiological follow-up, but the things are not so. And diffuse low-grade glioma technically includes all WHO grade 2 gliomas. We'll come to that, how this classification is not appropriate, the WHO classification. And then it's a broad group containing tumors that are clinically, histologically, and molecularly diverse. That is why we need to know in detail about them and how the current practice paradigms have changed. So this is older classification, 2007 classification. We have excellent talk. After me, Dr. Deshpande is going to present that. So I won't go into much molecular details. And basically, grade 2 gliomas include astrocytomas, oligodendrogliomas, which have a better prognosis, around 12 years median survival, oligoastrocytomas. Then anaplastic is grade 3 and glioblastoma is grade 4. So my Victoria's favorite question was, how do you differentiate grade 3 and grade 4? So the answer to that was necrosis and microvascular proliferation. But there are so many inter-observer variations in that, and we should not take that as an in fact, we should proceed to molecular diagnostics in gliomas so that we can prognosticate better and decide the treatment. So molecular and cytogenetic information is very mandatory, and as clinicians, we must tell the pathologist what we need in any glioma specimen. So basically, I would like to take you through a clinical scenario, and we would learn management of low-grade glioma through this case. That is what I wished when I presented this when I prepared this presentation. So she is a 29-year-old female. She was at Mumbai and she was getting treated for infertility, and she was found to have high prolactin levels. Intermittent headaches were there. So she was advised MRI brain for ruling out pituitary adenoma. So this was a MRI. The pituitary gland was normal, but there was a small lesion in the premotor region. This is the central sulcus, and this is the premotor region. Flared hyperintense and non-contrast enhancing. So, considering this small lesion, some history of fever, in fact, the diagnosis given was a focal encephalitis, and a differential of diffuse low-grade glioma was also kept. So, you can see this MRI was done with a pituitary protocol. So, the options here were wait and watch, operate, or radiate. So obviously the common option, all of us would have taken the option of wait and watch, and then she was kept on regular follow-up. She consulted my clinic in 2022. She shifted to Pune. She is an engineer. She still had headaches on and off, and I also saw the same MRI, and even I kept her on radiological follow-up. So, but I gave her anti-migraine treatment, and her headaches were typically of migraine only. But then I advised MRI after 3 months, repeat the MRI to see the progression of the lesion, which I would have anyway done in any other low-grade glioma. But then she was lost to follow-up, and then she planned pregnancies, and then she came to me after 2.5 years. And at that time, her headache frequency had increased,
and we decided to repeat the MRI. And this was the MRI at that time, and the lesion had significantly progressed. It had progressed anteriorly as well as progressed posteriorly and involved the motor gyrus, medial as well as lateral aspects, although she did not have any deficit. So now we have a situation that we have kept a small lesion on follow-up, and now it has progressed to an eloquent region, and also the white matter tracts are involved. And she is a young lady and with no deficits. So she visited many people, and obviously there were different opinions sought. This is a T2, it is hyper intense, and we can see it is almost extending along the white matter tracts. So we need to understand that low-grade glioma is not a static tumor mass within the brain, and it is rather a progressive and invasive disease, and it's a chronic disease. It will invariably progress, and some of them will even progress to anaplastic. So it's a continuously evolving lesion, and it invariably will progress to a higher grade and leads to neurological disability in some frame of time. Sometimes it might be few months, and sometimes it might be few years also. So I won't go into, as I told you, the current classifications. We should always see molecular genetics, and we have Deshpande ma'am, expert in that, and I'm sure she is going to cover all this. So I will just cover the clinical and important parts from neurosurgeon's perspective. We should always have IDH1, 1p19q coordination, ATRX, P53, and MGMT methylation. So IDH1 mutations, I will just cover in short. If the glioma is IDH mutant, they are less aggressive tumors and have a better prognosis than IDH wild. IDH wild invariably means a grade 4 or very highly malignant or invasive lesion. Then P19q coordination, all of us are aware about that. It represents oligodendroglial lineage, and it is associated. If the tumor has this deletion, it has improved prognosis in low-grade gliomas, and the tumors respond better to chemotherapy and radiation therapy. ATRX and TP53 typically are the other lineage, that is the astrocytoma lineage. Like I told, 1p19q is the oligodendroglioma lineage. This is the astrocytoma lineage. And then last, MGMT status, it has a therapeutic significance. That is why every sample or tumor specimen should undergo MGMT status. And if the MGMT promoter methylation is there, it improves the efficacy of temozolomide. So any precursor cell of glioma will either have IDH wild, that will be like GBM morphology, or it will be IDH mutant. If IDH mutant will have 1p19q, it is oligodendroglioma predominant, and if it is ATRX and TP53, it is astro predominant. So it has diagnostic, prognostic, as well as therapeutic significance. So typically it is the median survival can be predicted upon these molecular markers. If it is IDH1 mutated, ATRX P53 mutated, it is astrocytoma, survival typically around 7 to 8 years. 1p19q coordinated and IDH mutated, it is oligodendroglioma, survival is highest, like more than 12 years. And if it is IDH wild, it is survival is always less than 5 years. So as I told, there is no stable diffuse low-grade glioma, and it constantly grows. The typical rate is around 4 millimeter per year. Sometimes if it is anaplastic, it can be more also. And therefore, the concept of progression-free survival is not of much value in low-grade glioma. And it is not a well-definited tumor mass. It is always infiltrating, and it will spread along the white matter, like we saw in our patient. And they will finally evolve into anaplastic phenotype if left otherwise. And rate of transformation, typically incidence is 17 to 73%. And the median intervals for this is 2 to 10 years. So early intervention is the rule. So radiological diagnosis, we have Harshvardhan. So I think he'll cover that. All of us know that they are typically isoto hypointense on T1 and hyperintense on T2. But the epicenter of a low-grade glioma will be in the white matter or the subcortical. Contrast enhancement calcification is uncommon, but it is more commonly seen in oligodendrogliomas. And vasogenic edema is typically less often seen in low-grade gliomas because they are slow-growing tumors. DTA is very crucial because I told white matter pathways are always involved in low-grade gliomas. MR spectroscopy typically it will show increased choline and decreased NAA. So this was our patient. This is a oligodendroglioma which will IDH mutated, which will show decreased NAA because the neurons will be less and high membrane turnover, therefore increased choline. And typically astrocytomas might show the lipid lactate peaks because of necrosis. So let's come to prognostic factors, and these are very crucial. So these are very famous papers, and older age more than 50, astrocytoma histology rather than oligodendroglioma, presence of neurological deficits or score less than 80 PFS, and largest tumor diameter more than 4, and tumor crossing the midline. So these 5 things were associated with a poor survival. So let's come to the management. So either we can wait and watch, which I told is not a favorable option. Surgery either could be biopsy or decompression or supramaximal resection, radiotherapy and chemotherapy. So role of biopsy is very limited. We always tend to think that if it is eloquent location or deeper location, we should have only biopsy. But biopsy, the indications are very limited, like very diffuse lesions such as gliomatosis, and patients unable to undergo definitive procedure because of medical reasons. So let's come back to our case again. So young lady again with a motor cortex involvement. So we need to know because it's a slow growing lesion, we need to know where the motor cortex is shifted. So we cannot assume that once it has infiltrated the central, the motor area, that means the hand and leg area already gone inside the tumor, which was the earlier belief that glioma will be infiltrating always in the gray matter. So since the patient does not have any deficit, that means these areas are not infiltrated, they are shifted. So we need to know where they are shifted. So this is a DTI and fMRI, very crucial investigations for eloquent location. And we could find that the leg area and hand area were shifted posteriorly. So this was the mass, and these are the corticospinal tracts which are displaced posteriorly and laterally. So this was the fMRI with 3D reconstruction, and this is the leg area, and this is the hand area. So normally these areas will be larger, but in this case they have been compressed to a very thin area and shifted posteriorly. So this is a very crucial information when we are planning surgery for these patients. So this is the exact leg area and the hand area activation on gold signal. So we decided to go ahead. Activated by and then whatever tracks are between these 2 points will be delineated. Help us like this portion. So, being an eloquent region, I decided to use all the things in the armamentarium. So, I decided to use awake craniotomy so that I can monitor her in real time. Then DTI navigation as well as intraoperative monitoring and exact mapping of the hand and leg area. So, awake craniotomy. And this is, we have to fix the frame and the patient has to lie down in this position for a significant period of time, around 4 to 5 hours. So we have to finish the craniotomy and the procedure as quick as possible. So then craniotomy. And the premotor areas as well as posterior motor areas need to. So this is intraoperative. We use navigation. So I would like to show you the setup of an awake craniotomy. So another important thing in this case was intraoperative neuromonitoring. Although we know that the hand and leg area are shifted, that is seen on MRI, fMRI, but we need to confirm that during surgery. So we actually stimulate the proposed hand area and leg area and get the movements of the hand and leg and then confirm that during surgery. Then apart from monitoring of the hand function and the leg function, we also monitor the MEPs, that is strip MEPs. So because we are removing the cranium of that area, we cannot do the direct MEPs. So we have to do indirect MEPs in this case, and we have to put a strip on the motor cortex to continuously give electric current to the patient. And we cannot give very high currents because the patient is awake. So we have to give a low amplitude currents to these areas. And any drop in MEP which is more than 60% has to be, we have to stop the procedure, we have to irrigate with warm saline, then we have to give steroids and hydrate the patient from the anesthetist point of view. And once the MEPs again come up, then we can again start the procedure. So that is how MEPs are going to help us. But as I told, low-grade glioma is a disease of white matter also, and we need to know where the tracks are, that we already know from our DTF. But we need to stimulate also during surgery the white matter. So we have to take a monopolar probe and keep on stimulating the white matter. And the thumb rule is 1 millimeter is 1 milliampere. So if I am getting the corticospinal activity at 4 milliampere, that means they are 4 millimeters deep from my stimulus. So that is how we keep on going. And the moment we reach around 2 millimeter or whatever you have decided that I will not go 4 millimeter near the corticospinal tract, then we have to stop at that point. So you use the current of 2 milliampere and you are getting corticospinal, that means it is at 2 millimeter depth. And then you have to stop at that point. So all these decisions or planning you have to make in advance, that you are going to stop particularly at this place, because every patient is going to be different and he is going to ask for different outcomes. So this is an intraoperative picture, white exposure. And being a parasagittal lesion, always the veins will be there. It is very crucial to preserve veins from a surgical point of view. These areas intact, and plus I have MEPs also to have a soundproof hypothesis. So this is the tumor, and then I started the resection. Q size very crucial. At low power, I use usually 30 or 40 power. And this is the resection cavity. This is the hand area and leg area which were preserved. And this is the vein. We have to work under the vein and by the sides and keep on subtly sucking the tumor and keep the vein, because this vein is going to drain the hand and leg area. So keeping the vein is very important. So I usually do immediate post-op scans, and usually MRI is preferable to see how much I have resected, whatever I had planned, whether I have resected that much or not. And if I feel significant residue is there or things have not been according to my plan, I take the patient again in the theater and remove. So this was the immediate post-op MRI. It should be done to prevent the blood product artifact. It should be done within 6 hours from the surgical this thing. And this was immediate post-op MRI, and I was happy with the MRI. These you can see the blood products. So this is immediate post-op MRI, and you can see like we have. It feels as if we have removed the motor strip, but the hand and leg areas we should have preserved because we used all the technology. So she had dense hemiplegia for 2 days. I gave steroids, but that improved. I knew that hand and leg areas were intact because at the end of the surgery, the ETs were intact, and I could get the same stimulus hand and leg when I started the surgery at the end of the surgery as well. So I knew that it is intact, the fibers are intact. And then she developed hemiparesis, which is typically a SMA syndrome, because I had removed the supplementary motor area, and I had rigorously counseled her for supplementary motor area syndrome. And within 3 weeks, that also improved. And right now, she does not have any deficit. It is almost 1.5 years now. So this is the histopathology report, and it came as IDH mutant. Sorry. IDH mutant oligodendroglioma, WHO grade 2. But what comment they have given from data that despite lacking definite histological features suggestive of grade 3, the tumor shows elevated cellular areas, and possibility of impending progression to grade 3 cannot be ruled out. So that is how histopathology and pathologist is very important for us to decide the further course and prognosticate the patient. So this was a grade 2 oligodendroglioma, probably progressing to grade 3, 1p19q co-related, IDH mutant, and retained ATRX. And the proliferation index which they mentioned was high. So obviously this patient has to go for radiotherapy and adjuvant chemotherapy. And this is the post-operative MRI 3 months after the surgery, and this is the pre-operative tumor, and this is the post-operative. So we have resected, this is a flare signal of the gliosis, but we have resected what we wanted to. This is pre-op and this is a post-op. Clean cavity is seen, and even the white matter signals have now disappeared or reduced, if we can see in the post-operative MRI. Post-operative MRI. So that is how we manage the case. The patient is at present disease-free as well as symptom-free, and she has completed her radiation therapy. So just few slides. Extent of surgical resection is independently associated with survival, and you should keep less than 5 to 6 ml of tumor. That is the extent of resection, which is ideally advocated. So the conceptual shift from an image-guided surgery to a functional mapping-guided resection, that is how we can achieve supratotal resections even in eloquent areas. And conventional T2 and flare MRI does not show the whole tumoral disease. If I want to take out the flare signal in this patient, she would definitely land up with permanent hemiplegia. So we have to have functional imaging as well as functional mapping during the surgery. And plus awake. Awake is the gold standard. And image-guided surgery ultimately leads to good outcomes. Neural plasticity, definitely low-grade gliomas, they are slow-growing tumors. They will always displace the eloquent areas, either posteriorly, anteriorly, how they grow. And we should know the direction of displacement and the areas of displacement. That is how we can tell the patient that yes, you might have a temporary deficit, but permanent deficits are unlikely because it's a slow growing tumor. So the same concept which occurs in epilepsy, the development areas get shifted somewhere else, can happen in low grade gliomas. So this, although it showed that the tumor is evading the motor stick, we knew that the areas were shifted posteriorly and medially. An intraoperative mapping in an awake patient, more reliable method for identifying eloquent regions, very safe, inexpensive, does not require intubation, reproducible technique, and impressive outcomes can be achieved. So these are papers for functional mapping as a resection of low-grade gliomas in eloquent areas of brain and radiotherapy. I think we have radiation oncologist lecture. I will just cover 2 points: timing of radiotherapy. Whether if it is a low-grade glioma, we should give it immediate radiotherapy or delay. Because high-grade gliomas, we don't know that we are going to radiate them. So and the dosing. So there were multiple papers, and if we see, these are the patients in whom they did not give radiotherapy immediately after surgery, and these are the patients in whom they gave. And median progression-free survival is 3.4, and here it is 5.3. But the median overall survival is same. So that means immediate radiotherapy does not change the median overall survival. So radiotherapy can be postponed in low-grade gliomas until the tumor shows signs of recurrence only in low-risk patients. So we have already covered which are high-risk patients and low-risk patients. If the patient has 2 or more than factors for high risk, we should give them radiotherapy. And the dose, I think he'll be able to tell in a better way, but increasing the dose from 54 to 60 can lead to radiation necrosis, and this is the optimal dose. That is what studies are saying. And then temozolomide, we always know that it is effective in high-grade gliomas, but low-grade gliomas also respond to temozolomide, especially if there is 1p19q co-deletion and methylation of promoter methylation of MGM2. So this was proposed by Dufault. Dufault is I think he is a surgeon in the world who has operated largest number of low-grade gliomas. His operation theater, he operates only low-grade gliomas, nothing else. He doesn't touch high-grade glioma. He is in France. So he proposed neoadjuvant chemotherapy also, but there are no randomized control trials available to validate this. Another case of temporoinsular glioma, which I operated, this is a medial temporal as well as insular, and same technique, but without awake. This is the pre-operative and this is the post-operative, immediate post-operative scan. This is the pre-operative and this is the post-operative resection cavity. So I will summarize. These are not static benign tumors of CNS, but they are continuously growing and evolving lesions. Therefore, just observation is not correct for low-grade gliomas, and histological grading has to be supplemented by molecular and genetic alterations. Early surgery, if possible, supramaximal surgery is the key for maximal survival, good progression-free survival. But obviously, all resections have to be safe and discussed with the patients. And stratification of patients into prognostic groups is very important to plan adjuvant therapies. And CUSA, intraoperative monitoring, awake surgeries, DTI, and navigation guided surgeries are very important for favorable outcomes. Thank you.
Thank you, Amit. It was an excellent presentation, and you have demonstrated it so well, and proper utilization of all the technologies, and such a difficult to manage such a tumor. And I was wondering, this patient developed post of hemiplegia and
Yes.
then hemiplegia, and it was awake craniotomy and her intramural monitoring.
And she did not have any hemiplegia at the end of surgery.
Yeah, that's all. Means what
It is, I believe it is temporary stunning, and which we observe many a times. And it is basically a kinesis rather than.
is after how much time she developed hemiplegia?
So the moment surgery was over, when we shifted her to ICU, she was not moving. She was not moving. And otherwise, what is your end point of resection in case of speech area? So that's a very interesting question. So speech area again, although we have fMRIs for demonstrating Broca's and Wernicke's, we all know that Wernicke's is not a very focal area and Wernicke's is a very distributed zone. So we need to identify Wernicke's area very important. Broca's can be more or less anatomically same where the literature has described. So awake craniotomy cannot be replaced with anything else in speech. And white matter stimulation, which I described for motor tracks, is very difficult for speech areas because it's a positive stimulation. So patient will not speak. Like if I stimulate motor track, corticospinal tract, patient will have activity. But during awake, speech will not come when we stimulate the, in fact, speech will be inhibited. So it is very difficult to monitor with white matter stimulation. So precise identification, sometime if I get time, I will show the awake craniotomy for speech lesions also. So continuous monitoring of the patient real time during surgery, number one. And number two, stimulation by intraoperative monitoring. And we should always be conservative during speech resections. But yes, having said that, even Broca's I have seen improving. The patient developing Broca's aphasia, they have also improved because of neuroplasticity. Younger the age, better. But high grade lesions, I will not suggest aggressive resections like this. Only low grade gliomas, we should take that liberty. We have too many. Yes, sir, please.
So what we said, you see the brain gets spanned, and this we have seen time and again. For 2-3 days, they don't show any function, and your heart stops, and gradually they started. So that's very common. Is it working? Yeah. Yeah. Secondly, my question to you is, you say both Broca's and Wernicke areas. When we are talking about language function, we are talking about only verbal speech. But it is not so. Both, you see, there can be speeches of written also, verbal also, gestural also. Yes, no, even that is a speech.
That is also a speech.
Now, you see how to identify, because you can say whatever he talks. Are you going to really examine his speech, both motor and sensory speeches of Wernicke's and Broca's area from different angle, gestural, speech, verbal, and then written? Because even if one is gone, particularly the written one is gone, he is half, incapacitated in that particular function because he can only talk, he cannot write actually.
Broca's, it is very easy to identify during surgery because, as I told, Broca's is a very focal area, and the patient will be talking 1, 2, 3, 4, 5, 6, and if you stimulate Broca's, suddenly he will stop. So that is a complete speech arrest. So Broca's is very easy.
I know.
Wernicke's, as you told,
even Broca's. Please, what I'm saying, verbal is okay because you can test. What about?
Yes, that is difficult to very challenging.
Fantastic. I built them some charts. There are charts which are available. First, we need to identify the area which is this one is likely to import. If it is Broca's, we should more focus on Broca's. If it is frontal hybrid, we should more focus on frontal hybrid. Then we have to take the chart.
Yeah, we have pictorial charts. But still, as we said, some functions are very difficult to ask.
One question. Nice to see you after a long time. And you're doing lovely work. So congratulations for that. My question is that suppose you think that the tumor is significantly present on our immediate scan, immediate MRI. So how early or how late do you take the patient for re-exploration? And when you take this patient for re-exploration, what is your plan now in the second setting? Because you've already, given your best in the first, and probably there must be some reasons why you stopped early, right? So what is your plan the second time? And then what is your plan of action?
Exactly. So if you have planned something and things went as per your plan and you are expecting a residual lesion, then no need to go back again. But suppose there can be always misjudgments. And even I have had misjudgments. I have left epileptogenic lesions, and I thought that sometimes
we are misguided by technologies. Sometimes navigation doesn't work, brain shift occur, and then you feel that yes, some tumor might have left behind, or you may not feel so, but the MRI is showing a significant tumor left behind or a dysplasia left behind, for example, in epilepsy cases, and that is not as per your plan. You have decided for a supramaxillary resection or resection in that region, and it is not showing. Then you should take the patient, I think, immediate, or within 2 3 days also you can take that also. I have done for epilepsy cases that explaining to the relatives, and then but what I feel is the MRI you do post operatively should be within 5 to 6 hours after the surgery, because the blood products throw tremendous artifacts later. If you do MRI next day, then the things are going to be difficult, and then you fuse this MRI with a preoperative MRI on navigation and then compare them.
Thank you.
So I would like to give one input regarding speech mapping, sir. Now, current understanding is like the speech is not topological representation. Not it is not only Broca's or Wernicke's. With current understanding of connectomics, we know that we have a white matter pathway.
Exactly.
So Hickok and Popper model is the new model of language. So we have ventral pathways and dorsal pathways. So ventral stream is by SLF, which we can map with subcortical mapping. It is associated with semantic paraphasias, and the dorsal stream is with IFOS pathways. So like we were monitoring corticospinal tract with subcortical mapping. So for semantic paraphasias and this thing for IFOS,
Mistake.
yeah, patient start there is a pyramid and palm tree test, so that we can use as a motor mapping or like subcortical mapping in language pathway. So that will cover every aspect of language. I believe what sir was saying, gestural and all things will
Not
be
everything,
covered.
I would say, because I have seen many times that the patients are not intact during surgery, and after surgery they have developed speech deficits.
Yes.
Not very dense deficits, but yes, they are unhappy. Like sir is saying, I am not able to read properly. I am able to answer proper questions. But anomia is a very common thing which they develop despite of taking proper names during surgery. So there are certain, like all pathways are, I think, yet to be involved, and there is not a, how many areas are you going to check now? It is impossible. It is impossible to check from superior temporal gyrus posteriorly, curving along and then coming to Broca's.
So that is what like preoperatively what we are assuming and we are mapping, and luckily if we are getting we can preserve.
Exactly. So we can do common tests, as you rightly said, as Dr. Pankaj said, pictorial test, even visual eye fields we can check.
Yes, sir.
Rotating drum and everything, it is available now.
Available, yes. Thank you, sir.
Yeah, we had a good discussion. Thank you, Amit.
Sir, what about the incorporating 5-hour diet in such cases? Because if we are focusing on maximal resection, so if we are looking intraoperatively through the microscope, which are based on 5-hour diet identification, so we can look for more maximal resection if we are sure that we are away from the cracks, what we don't want to, you know.
So yes, that is a good suggestion, but 5-hour usually will be taken up by higher grades of gliomas, not low grade gliomas.
Yeah.
And the cost also is a factor. Plus, I would say that the infiltration along the white matter is not very well seen with 5-hour, even in high grade gliomas. So that is, and eloquent areas anyway, there is no option but to check by awake. We don't have any option for that. And anyway, if it is not eloquent, for example, frontal lobe, then you can straight away chop frontal lobe with a wide margin, like oncologic resections, you can do supramaximal, 7 centimeter, 8 centimeter, going 1 centimeter behind the tumor margin without entering the tumor. That also can be done. Problem comes with eloquent. That is why I typically chose this case.
You know, neuro navigation fails sometimes.
Yeah, it can fail. It can fail, yes. It can fail, definitely. That is why I told. See, sometimes we get unexpected MRI scans also.
But reliability of navigation increases from this.
Yeah, intraoperative.
I try.
Yes.
The moment CSF is brain, the brain shifts.
Friendships.
Navigation helps in demarcating the tumor. You can outline tumor, but once you start resecting,
Yes.
then you may not rely much on that.
We cannot.
Yeah. Thank you so much, Amit, for coming all the way from Pune, and that too on a short notice. So, welcome next speaker, Dr. Makarand Randive. Dr. Dhruv is going to introduce.
So I would like to thank Dr. Makran. I think he was the first speaker who came to my mind as a retaliation to the surgery guys who were held to who will have a surgical speaker as a glioma. के लिए. So I thought our choice of person could not have been better than Dr. Makran. So he'll be speaking on the medical management of glioma because many of these cases we just know the names. We know temolizumab, we know some drug, we know IDH mutation, but what I asked him specifically was we want some take home points that at the end of the day, we should know which chemotherapy to be used in gliomas, whether we can have some contribution to it as well, and to give a brief perspective that how medically gliomas are managed. And it is not all surgery and how to manage medical this thing. So thank you, Makran, and I will leave you to it. Thank you so much.
So, good evening to all seniors and colleagues. It has been a great honor, and thank you, Nagpur Neuro Society, for this opportunity. So, my talk will be based on the following outline: the epidemiology, WHO classification, mutations, the management, role of gliomas, grade 2, grade 3, recurrent high grade gliomas, and what the future holds. So basically, this is the Indian data which I compiled. Incidence of CNS tumors, entire CNS tumors, it is 5 to 10 per 1 lakh population. And compared to all the malignancies, it accounts for 2%. Males are 68%, female 32%. The ratio is 2.1:1. And the frequency of brain tumor according to age, it's highest in the 31 to 40 years. So there are three major classifications which during the professional which I know. One is in 2007. The next major update was in 2016. It was, I consider, a major shift because previously it was entirely based on the histological part, and a major molecular shift was done in 2016. And the latest one is in 2021. So I'll just touch the glioma part. So adult diffuse gliomas are subsumed within a super category of glioma and gliomerular tumors and are split into three subtypes: IDH mutant astrocytoma, oligodendroglioma, that is 1p19q co-deleted and IDH mutant, and glioblastoma, IDH wild type. And WHO grades further specified for CNS tumors, including diffuse gliomas. So IDH mutant astrocytoma, it could be grade 2, grade 3, and grade 4. Oligodendroglioma, 1p19q co-deleted, and IDH mutant, it will be always grade 2 or grade 3. And glioblastoma, IDH wild type, will always be grade 4. And along with it, the classification also takes into account the importance of molecular data for accurately diagnosing the CNS tumors. So the mutations has already been covered, but still, just for the revision sake, I will just try to put it down. IDH1 and 2 mutations with 1p19q co-deletion, the combination, mostly oligodendroglioma, it signifies the improved PFS, longer time of treatment failure when we do the treatment, and extended overall survival benefit. The IDH1 and 2 mutation without IP or 19q co-deletion, PFS much better than the other astrocytomas and the glioblastoma. IDH wild type is the worst prognosis of all. Then MGMT is basically, it's a promoter methylation is present. It's a predictive factor for the treatment response with the alkylating agents which we use, that is temozolomide and lomustine. TRT mutation, it is diagnostic. Absence signifies towards astrocytoma, and prognostic in the way is presence associated with IDH wild type, and it signifies the poor prognosis. Then comes the CDKN2AB homozygous deletion. The presence of it signifies the grade 4 status of IDH mutant astrocytomas. ATRX mutation, it is associated with IDH mutation and TP53 mutation in general. And it has been found to be mutually exclusive of 1p19q co-deletion, and it is also diagnostic of astrocytoma. Then H3K27M mutation, very poor prognosis, usually classified as grade 4. So
how do we progress? Generally, we see for the histology first, then we divide whether it is IDH mutant or wild type. In IDH mutant, we go for 1p19 Q deletion, ATRX 5253. If Q deletion is present, label it as oligodendroglioma, and according to the histological features, pathologists will label it grade 2 or 3, and that's how we reach the diagnosis. If ATRX loss or TP53 mutation is there, ATRX, as we have already seen, denotes to astrocytoma IDH mutant, then microvascular proliferation is seen. If it is present, then astrocytoma IDH mutant grade 4. If it is not present, then we look for CDK and AD and to whether deleted or non-deleted. If it is deleted, then again it goes out to be astrocytoma IDH mutant grade 4. If it is not deleted, then histological features are seen as we are seeing here, and accordingly it is labeled as grade 2 or grade 3. IDH wild type, generally from the medical oncology perspective, we generally stop here. IDH wild type. This entire thing is of importance to pathology because wild type has got a very bad prognosis, and any IDH wild type from medical oncology point of view generally denoted as a glioblastoma grade 4. Definitely, there are some other histological features, but prognosis wise, not of much of use. So, what are the predominant drugs we use? We use procarbazine, lomustine, vincristine, that is the PCV regimen. Then temozolomide, bevacizumab, irinotecan. Then we have got some targeted therapy in the form of larotrectinib and entrectinib, they are the NTRK inhibitors. And if BRAF mutation is present, BRAF V600 is the mutation generally present in pediatric or pediatric low-grade glioma or SIGAs. But even in some cases found in low-grade gliomas and high-grade gliomas. So in that case, dabrafenib and trametinib is the drug. So coming to IDH mutant, 1p19q co-deleted oligodendrogliomas in adult. So maximum safe resection still holds the basic and major importance in the treatment. We look for tumor grade, whether grade 2 or grade 3. If significant residual tumor is there in post-op, then we go for the treatment. We had already discussed the duration where we can stop. Where we should go for observation, there is also a chance of observation if significant residual tumor is not available. And for WHO grade 3, we directly go for the adjuvant treatment. So this is the NCCN guidelines which we follow. Here we can see WHO grade 2 glioma. We look for the performance status, Karnosky performance status. If no residual disease, observation is the first option to be used. And if residual disease is there, standard radiation plus adjuvant PCV, that is category 1. And standard radiation plus adjuvant temozolomide, here it is a category 2A, that is less substantial evidences available for that. So what are the variables favoring wait and watch? Grade 2 histology, minimal post-op tumor volume, documented low pre-op tumor growth, and oligodendroglioma histology. Variables which favor radiation and chemotherapy, that is grade 3 histology, substantial post-op tumor volume, documented high pre-op tumor growth, contrast enhancement on brain MRI, poorly controlled seizure, neurological deficit, unfavorable genetic alterations which we have seen, and astrocytoma histology. So the basis of treatment in grade 2 oligodendroglioma forms this trial RTOG 9802. Probably this will be covered in detail by the next speaker. So when this trial came, it was a long duration back, almost 10, 12 years back. At that time, the classification was different. Astrocytoma, oligodendroglioma were mixed. So, but still, the majority of the patients were of oligodendroglioma, and we can see the estimated survival, median survival was around 13.3 years, one of the best. So, this trial used radiation plus PCV. Coming to IDH mutant, 1p19q co-related oligodendroglioma students on grade 3. So there is slight amount of difference. Instead of observation, we directly go for standard RT plus PCV, that is category 1, and standard RT plus TMZ, that is temozolomide. So this is category 2A. So as we can see the NCCN guidelines, the guidelines which medical oncologists or radiation oncologists mostly follow, the category one is only for the PCV because there is very less substantial amount, less amount of evidence for temozolomide of any given benefit in a low-grade glioma. Definitely for astrocytoma, it is given with radiation. Temozolomide works wonders but not with gliomas. And trial has also been conducted as independent, leaving apart the radiation only to temozolomide or PCE. So in that arms, definitely the overall survival is equally matched with almost if single radiation was given. So the basis of the treatment rate through glioma are these two trials. We can say in an intention to treat populations, there was a benefit. Almost the median was achieved at around 8 to 10 years. But for 1P19 coordinated, there was early and wide separation of the Kaplan-Meier curves. So this showing the very good benefit in 1P19 correlated tumors. So overall, these trials form the entire basis of the treatment. If you can see the hazard ratio almost ranges between 50 to 60, except for the PCM and oligodendroma grade 2 that is 0.21 and 9802 RTAG that is 0.38. And median overall survival ranges between almost around 12 to 15 years. These are the Indian trials, Indian settings, as Dr. Jalali, Dr. Anand, Dr. Julka, and Dr. Goda. These are the significant trials. These are one of the kind of prominent personalities in Indian oncology scenario. And majority of these have got a substantial amount of patients. And these trials have been conducted with temozolomide. They have shown good response. But because of the low number of patients and histology being mixed astrocytoma, it has not been substantiated. So coming to the important regimen, PCV regimen, what do? We give a 8-week cycle length preferred for grade 2 tumors based on the regimen used in RTAG 9802 trial. It is of 6-week cycle. The 6 week length of the cycle is 6 weeks preferred for grade 2 tumors based on EORTC 26951, as I mentioned in 2 different trials. So each cycle dose is lomustine is given at 110 milligram per meter square orally on day 1, and procarbazine is given at 60 milligram per meter square orally, and vincristine as 1.4 milligram per meter square capped at 2 milligram on days 8 and 29. So coming to temozolomide regimen, temozolomide can be given along with radiation and in an adjuvant setting. The majority as a medical oncologist or the radiation oncologist also, we generally use temozolomide even in a low-grade glioma setting during the radiation. But contrastly, there is very less amount of data to support. But compared to PCV, the availability and the tolerance-wise, it is good. So sometimes it is used off-label without any much of the evidence. So concurrent with radiation, the dose is 75 milligram per meter square once daily for a maximum of 6 weeks during the radiation therapy. I generally prefer to do gap on Saturday and Sunday when radiation is not given. And during the adjuvant setting, the cycle 1 we give around 150 milligram per meter square to day 1 to day 5 in a 28-day cycle. And from cycle 2, depending upon the tolerance, we increase the dose to 200 milligram per meter square. So coming to TMZ versus PCV, the major differences is unclear whether the TMZ is equally effective as PCV in oligodendroglioma. Astrocytoma, there is some amount of data definitely working. Both regimens have activity in oligodendroglioma. In some small setups or in a case report, definitely there are some favorable results, but no head-to-head trials has been done. Only PCV has been investigated in randomized trials. And majority in our setups, in Indian setup, TMZ is used because of the ease of administration, better patient tolerance, more consistent of availability compared to lomustine, and efficacy of combination RT supported by indirect evidence in other types of gliomas. So coming to recurrent high-grade glioma, we see for the during the management, we see the performance status. If it is good, the local pattern of recurrence or progression or diffuse. If it is there, is complete or near complete resection possible? If it is possible, then we resect and go for systemic therapy. If it is diffuse, then we directly go for systemic therapy. I will commit to it. If it is poor, the performance status is poor, patient is not able to get a neurological deficit, then we see further whether this PF is primarily driven by peritumoral edema and steroid toxicities. If it is yes, then we go for bevacizumab trial, and no, then best supportive care. So for all these in the guidelines, rather than going for any defined treatment, the guidelines says you have to go for clinical trial first. There are many clinical trials going even in India and abroad. So the first and foremost option to be given after maximum maximum resection is done is for clinical trial rather than going for any PCV or TMC. So in a metastatic, in a high-grade recurrent setting, the drug of choice which we follow is bevacizumab, that is 10 milligram per kg on day 1 and day 15 every 4 weeks, and 15 milligram per kg on day 1 and day 22 every 6 weeks. Generally, bevacizumab we combine with lomustine or bevacizumab with irinotecan. Lomustine has to be given every 6 weeks, so generally I follow this 15 milligram per kg regimen. That is easy for the compliance and to call the patient and give the drug. So what the future beholds, these are some of the drugs: ivosidenib, vorasidenib, olutasidenib, and safusidenib. It is the IDH inhibitors. Of this vorasidenib, it has completed phase 3 trial. Vorasidenib is the IDH1, IDH2 mutant inhibitor oral drug. The dose is around 40 milligram. And you can see the PFS Kaplan-Meier score. It's very well separated, very early separated, and the hazard ratio is 0.39. That is almost 60% benefit for deaths and mortalities. So what are these? CAR V3 T cells, interleukin 13 are alpha 2 targeted CAR T cells, and bivalent chimeric antigen CAR T cells targeting EGFR and interleukin 13 are alpha 2. So basically, this is a CAR T cell therapy. The first trial which has been done, it has been done in 4 to 5 patients, but phase 1 and phase 2 trial has been done in a glioblastoma setting and some patients of recurrent high-grade glioma. Excellent results. Excellent results in the sense the CAR T cell therapy was given, and within a substantial amount of time, the effect of the tumor regression has been seen without any neurological deficit. Presently, only the safety and efficacy trials have been performed in this. So this trial has been done for around 3 to 5 patients, and it is targeting the EGFR receptor. The second one is the interleukin 13 alpha 2. This trial has been done in around 65 patients. The response is one of the excellent responses. And third is the bivalent chimeric antigen. That is the 2 antigen they have been combined and then developed the CAR T cell therapy. So just a word about CAR T cell therapy, how it works. So generally CAR T cell therapy is a new concept. Many of you must be knowing it. Majority working in leukemias, lymphomas and multiple myeloma, and it has achieved a breakthrough results in it. So we generally go for leukophoresis, collect the patient's white blood cells, then it goes for the manufacturing of the CAR T cell. We isolate and activate the T cells. Then generally it is the T cell is also engineered with viral vector CAR DNA. The bacteriophage is used, and the engineering of that T cell is done by the required CAR gene. This engineered CAR T cell is done by method of PCR. It is expanded. It is transported back to the hospital, and the infusion it is infused in the same patient. And the activity after that, the activity goes on. So median manufacturing time for this is around 17 to 28 days, and patients undergo lymphodepleting, that is bridging therapy, just like we go for any kind of stem cell transplant.
So these are the approved CAR T cell therapies. The indications are different. It is not related with the neurological. It is for hematological malignancies. And these are the some CD19 targeting therapies. As we have seen the EGFR and interleukin 13 alpha targeting therapies, these are the CD19 therapy. These are the name exicaptagen, simulusal, brexucaptagen, nautilus. What are the international CAR T cells? CAR T cells are quite expensive right now. So in 2015, 2016, IIT Bombay and TMH collaborated and they tried to develop indigenous technology. And around in 2022, 8 patients of trials were done that was exclusively in leukemias and lymphomas. The major benefit when CAR T cell therapy started, the cost was around 2 crores, and it was also not very easily approachable. Whenever patient used to ask, well, we can go to the US and get a CAR T cell therapy, we have read about it. So it was not very easily approachable because they have to undergo a lot of hassles and to go into the trials. But because of this, the cost has drastically reduced, almost 90% reduction in the cost, and a reliable illness product we have. So April 2024, this formal launch was there. First homegrown gene therapy for cancer developed by IIT Bombay and TMH and Immunoact. Immunoact is the company which has taken the entire responsibility of making this CAR T. Because basically patients get admitted in the hospital, you have to contact Immunoact. That has been some terms and conditions MOU has been done in that hospital. Patient undergoes all the precautionary by all the immunodepletion by busulfan or melphalan, and then the CAR T cells are sent to engineer to Immunoact, then they say that, and we do the CAR T cell therapy. So to conclude, CNS tumors major benefits still lies with the local regional treatment, surgical and radiation. The chemotherapy data is definitely not so much progress. It is definitely as assistance to the local regional therapy. Majority of the radiation, if we take out the radiation out of the therapy, the chemotherapy probably will be handicapped. Toxicity and availability is still a major challenge in case of CNS tumors. But in future, multiple targeted therapies are in pipeline which are showing promising results. Majority of them are oral drugs. And as mentioned, not the majority of the trials has been done in neoadjuvant setting. So probably once the oral therapy and CAR T cell therapy has been done, if it goes into phase 3 trials, probably we will have the benefit into some neoadjuvant setting. Just to take the oral drugs for 3-4 months, reduce the size of the tumor from 6-8 centimeters to 1 or 2 centimeters. Probably that will help in preserving much of the functional areas. And yes, CAR T cell therapy, it is expected to be a game changer. So thank you.
Yeah. Thank you so much. You have covered the topic extensively. I think you are running late. So we can have questions at the end of all the speakers, right? So as a neurosurgeon, I feel glamour section is much easier and the classification into subtypes of glamour is more difficult. So we heavily rely on the histopath report and we heavily rely on the neuropathologist like Dr. Kamyani Deshpande ma'am. So I invite her. I spoke to her maybe some 100 times in last so many years, but I never. So thanks to Glamour update.
Same is true here. I've spoken to so many neurosurgeons, but I get to meet them for the first time, even including.
And we are running late. Himanshu, if we can keep the next speakers also ready so that we won't waste much time.
I'll try to finish in 10 minutes. I was just thinking everyone is allotted in 10 minutes. CNS tumors.
Yours.
मेरा तो I've loaded already. I've loaded in here.
This one.
नहीं CNS tumor. Top of that, I think. Yeah.
This one.
Yeah, sure. So I'm really glad to the Neurology Society for inviting me, because I always feel with this changing scenario of pathological tumors in every system, it is very difficult, to be on the same page with your clinical colleagues, because pathology tumors are changing so fast because of the advent of new molecular markers coming up, biomarkers are coming up so fast. As you have heard in previous two lectures, there are so many tumor markers which are being introduced, and because of that, the whole classification has been changing from the basic histology, which we used to rely on light microscopy, to absolutely in the molecular laboratories. And I think sooner we'll have a classification of WHOs where they'll not be go by the organ, but will go by the tumor biomarker arrangements, and the classification will be like some deletions, and they can cover maybe a renal tumor, the CNS tumors, or a lymphomas from variety. So with this, I'm very glad that we can have a dialogue with our colleagues and know whether what they expect from us, and as a pathologist, what I can offer to them, so that they can have a better treatment of the patients. So instead of selecting, individual tumor, I thought why not go through a new classification of CNS, WHO 2021, fifth classification, because they have really changed the scene for a pathologist in CNS tumors. As previous people have covered, the first change happened in 2016 when the molecular studies entered into the classification of CNS tumors. Before that, the tumors are very simply classified grade 1 to grade 4 depending upon the RTPM, mitosis, necrosis, microvascular proliferation. And the proliferative index Ki67. These were the only players in the tumor classifications, and it was very easy for pathologists like us who were operating in a small scale laboratories with light microscopy. And we could offer our clinicians and our neurosurgeons a better diagnostic. But 2016, WHO introduced molecular biomarkers into classifying the tumors, and the whole scenario changed. And really, 2021 fifth CNS tumor is absolutely totally taken over by the molecular, and we as a pathologists, histopathologists have entirely taken a backseat. So what is this tumor, which we are always talking IDH mutant and this markers, biomarkers adding prognosis. So we are not only changing the diagnostic modalities, we are also adding prognostic factors. They are also giving targeted therapies, so that as Dr. Nandini has spoken, with one biomarkers, you can have a specific targeted therapy and the cure is in your hand. And apart from this, they can also put patient in the exact clinical trial, which is required for the growth of the treatment. So what is the taxonomy of this tumor of CNS is, we have combined histology and molecular features. And multiple novel techniques like initially we used to have this DNA, RNA arrays, assays, fish and all, but now we have like molecular biomarkers with DNA methylome profile. And really this DNA methylome profile has what changed the scenario. They're classifying the tumor, they're producing new entities which has been added. There's a list of tumors which has been added to the WHO 2021 for the first time because of this profiling, which has gotten new markers in hand. So what are we looking at? Why I'm taking you through this is because now my report has entirely changed. If you have received my report before this classification, it would have been a different thing, simple oligodendroglioma grade 2. Finish. Good. I'm good enough with some maybe IHC markers and all. But now I cannot stop at that. So I'll take you basic from what has changed, and where I can offer you as a pathologist is one is gradation. That CNS tumors has always been graded differently than non-CNS tumors because of there's some peculiarity which I'll cover. So in 2021, what I used to add Roman numericals like oligodendroglioma, Roman 2 letters have been shifted to array big like 1, 2, 3, 4. It is simple as that. You see the change is only, we'll feel okay. In the writing, I'm writing from Roman to Arabic 1, 2, 3 number, but the impact is that anaplastic word is taken away. There is no more anaplastic astrocytoma, anaplastic oligodendroglioma, and with this small change, a big word has been taken out away from my report, and all are written as grade 1 to 4. No anaplasia has been added, so they don't want that topographic error can happen. See, when I used to write anaplastic astrocytoma, it was grade 3 Roman, but now there is no anaplasia. So my my typist can make grade 3 when it is not anaplastic and it is actually grade 2. So prevent that. 2021 has taken away the numericals also changed, and definitely make a bring a uniformity with other non-CNS tumors. Grading has come across within the tumor type. Like initially it was grade 3 meningioma, grade 3 astrocytomas, grade 3 is uniformly given that. But the prognosis of astrocytoma grade 3 is entirely different from prognosis of meningioma grade 3. Their biological behavior was different. And there is, but when you give a grade 3 to both of them, you think they are equally at par, the prognosis and all is at par, but they are not very different. So this time they have only grading within the tumor. If it is astrocyte, if it is gliomas, they are graded within the gliomas and not graded entirely to CNS. And no grade is assigned to a clinical course where you don't know that what is the clinical outcome. Like medulloblastoma, as we know previously, is all grade 4. But there are some molecular biomarkers that come up and with targeted therapy, like example, WNB activated medulloblastoma, which have an excellent prognosis because of the targeted therapy. So they are actually moved from grade 4 into grade 1 because of their targeted therapy. They are still grade 4 tumor, but such an excellent treatment is available that they are moved to grade 1. So do I label it grade 1? No, because if I label it grade 1, it looks benign. Do I label it grade 4? Then I'm giving a bad prognosis indication, but it is in the middle. It is a good prognosis with the targeted therapy. So for such tumor, they have suggested stop grading. So from changing the numericals to stop grading to a high grade tumor like medulloblastoma, this is what we are offering you now. These are the simple grade. We keep repeating this and you must have seen. They are defined into the grades. And why grading is combined with now in 2021 with the molecular markers. I just cannot grade it without doing a molecular marker. So why is this done? Because as we have already covered, I will give you the example. There are some tumors with some mutants which have a good prognosis as compared to others. So, like example, IDH mutant astrocytoma is graded 2 to 4, and glioblastoma IDH wild type is definitely a grade 4. So, all these mutation biomarkers has to be included in grading, and it should not simply by histological grade. Or by necrosis and vascular proliferation. I don't want to grade every tumor as grade 4. And absence of necrosis and vascular proliferation does not make it grade 1. So example is here, WHO grade 2 or 3 IDH mutant diffuse astrocytoma with some homozygote deletions can be graded as stage 4 in absence of necrosis and vascular proliferation. So my histological criteria is taken away by me, and one biomarkers and one deletion or one addition of some protein will define the staging or grading of my tumor. So these are the 3 examples. So how the biomarkers have shifted the gradation in CNS tumors. Then they have added 2 categories. The categories are very specific that if I write astrocytoma NOS, that means I have not had an ancillary technique of molecular study with me to grade it. So my oncologist should know that my report is incomplete and I'm writing astrocytoma NOS. So either I have not done the molecular testing, or I have not done but not indeed the results, or I have not deliberately not done in some cases which does not require because they already have a bad prognosis. Another criteria we have added is not elsewhere classified. Like after doing all the ancillary techniques, I couldn't classify into the given format of WHO. So I have given this provision to add my report. All these parameters are added so that the oncologist or an oncosurgeon who is treating the patient should know what my report is giving them. Then we have added 2 more criteria, essential criteria and desirable criteria. Like if I have a tumor which I want to diagnose medulloblastoma or glioblastoma, there are criteria which must be in my report or in my slide to call my tumor to call it glioblastoma. And there are some which are desirable, but if it's not there, it's okay, I can still label it. And this criteria is again added because there are a lot of biomarkers which are now essential to put a tumor into a particular category. My astrocytomas should have IDH mutant, my glioblastoma should be IDH wild type. So all these criteria, that's why they have put essential and desirable literally in a tabular form so that one cannot get confused. So what now I'm getting with all these parameters WHO put in that you have to have this report, I get a layered or integrated reporting. Initially, I only used to get the site, my histological morphology and my grades, and I'm done. But now I cannot do that, but I have to have a molecular information. Like for example, I have a tumor in frontal lobe left. My integrated diagnosis will be oligodendroglioma, my histological diagnosis, IDH1 R1 32H mutant with 1p19q deletion should be my molecular. And then I will grade it, what grade it is, and then I'll give the molecular information. Any part missing out of this, then the oncologist have to work on what kind of treatment he is going to give. Is my report incomplete? I cannot miss any of this. I cannot just give like what I'm giving all of you because I'm sitting in a lab where I don't have an access to molecular, but I always write NOS. I have not done molecular. Proceed for the molecular and immunohistochemistry before you decide, prognosticate or decide any further treatment on this report. So gliomas, like I have told you, they're classified into adult type and pediatric type, depending upon the age and the prognostic. Pediatric type can rarely be seen in adult type, adult can be seen in pediatric, but basic characters they have taken and again on the molecular basis, they have divided gliomas into two types, depending upon their prognostic and biological listing. And what nowadays, like there were 6 entities in gliomas, like astrocytoma grade 1 to 3, astro-oligo combination was there, which is all been removed. If you have a molecular signature, they are clearly classified astrocytoma, oligodendroglioma, or glioblastoma. There is no combination of astro-oligo anymore after the biomarkers. So you have to report like this. Then there are newly recognized tumors in glioma. I'll not go into the list. There is list, but see, there are a lot of categories depending upon if it's H3 G34 mutant diffuse, H3 wild type, IDH wild type, and they have taken the molecules and whatever signature they are putting. And you can have a newly recognized so many tumors in the list, and this is rather impossible into a histological pattern. They might overlap histological pattern, but because of specific signature, if you can see in the last part of all the tumors, they have specific molecular signatures. And that's why this classification has come. And why this is needed? Because now we have a targeted therapies available to most of these tumors, and they do excellent. Of course, as when Dr. Ramdash said, it's basically higher grade tumors are neurosurgeons domain, lower grade tumors are both domain, and recurrent and bad prognosis is again a medicine's domain. So, with this criteria, we have a list of tumors coming up, and chances of patients receiving a good therapy also is up. The revised nomenclature, as we have already discussed, I don't think that anybody will be interested in this. Depending upon the molecular signatures, they have revised the nomenclature and placed the different criteria, like solitary fibrous tumor was now clearly, angioparasitoma is gone and clearly defined as solitary fibrous tumor grade 1 to 3. So many changes have happened in this. And before I end my listing, I just wanted to convey that, frozen section and cytology is very underscored in diagnostic modalities with neurosurgeons. They are really a great ancillary technique for both diagnosis, and frozen section have some limitations, but if you combine with cytology, especially in low-grade lesions where frozen can be because of the softness of the tumor edema, frozen section can be difficult, but if you combine with cytological smears, they both can give a very excellent diagnosis, good for metastatic carcinomas, high-grade gliomas, and non-neoplastic inflammatory lesion like tuberculosis and all. Frozen and cytology is a good modality. There are some examples like in glioblastoma. First is the frozen thing which you see a vascular proliferation so nicely, and in the frozen you can compare that it is a high-grade glioma with vascular proliferation, pedicidal necrosis. Similarly, metastasis can be easily picked. So many times in spine tumor, we have seen a metastasis coming from thyroid follicular carcinomas interpreted as high-grade because they are very vascular, and they turn out to be metastasis. For such lesions, I think frozen and cytology combination is a good modality. So what I conclude as a pathologist is there is an exponential change in the CNS tumor terminologies, and because of the advent of molecular profiling. And layered reporting is essential part now. Nobody can give a simple histopathology report in CNS and say it's a complete report. You have to have an molecular profiling done in each and every case before you even think of starting a treatment. Category of NOS and NES is provided for people like us who operate in a small restricted laboratories, but definitely we are not doing a good job with CNS tumor. You need to have a molecular laboratory support with you. And as I told you, all this WHO thing is not a gimmick, it is not a fashion design, but it is definitely done with the very intention to give a targeted therapy with an excellent prognosis for each and every patient. And classify the patients into particular categories so that they can be selected for the clinical trial with a very clear reporting on your hands. You know this drug you are opting because the patient has been classified with a layered report into this group. So, like Dr. Randinia said, these clinical trials are going very heavily nowadays and you have to have a very strict criteria of selection of your patients. So pathology layered report is there to help you to guide you to enroll the patient in clinical trials. And definitely this all classifications are showing us that there is a work in progress. There are pediatric diffuse low-grade gliomas which are still being even documented in WHO. There are still many molecules which are yet to be identified. And once we identify, we are going to split these gliomas again into multiple subtypes. There are a lot of offerings coming from WHO with this. So the end conclusion is whether to lump or to split is the question. And I'm very sure the medical oncologists will definitely like to split a lot and get their targeted therapy. Thank you.
Thank you so much, ma'am, for your crisp and absolutely simplified presentation. And just one request, like you report, the way you report, layered reporting, is it possible for all other pathologists, histopathologists, or means how do you train other histopathologists in your community? Because it's a big.
Yes, so that's what I said. I'm very grateful to the Neurology Society because fast changing.
Because if we send specimen to 3 different pathologists, we get 3 different opinions.
That is another story, but at least when we are in the dialogue, we are on the same page. To ask certain things that we need to put in certain way, and I'm able to give it that way. And for this dialogue, I think that
that's right.
We have a dialogue with the solution.
So I think just a small comment here that I train movement disorders at NIMHANS and Dr. Anita Mahadevan is doing excellent work there. So what they usually do is, I think this is a food for thought in the future that we can have neuropathology, because actually neuropathology is the gold standard of all neurological disease. So maybe with your initiative, madam, we can have some small Zoom lectures which we are planning, wherein you can tell us actually, I think none of us as a neurologist has ever seen a biopsy of a CIDP. I mean, we diagnose so many CIDPs, but we have not actually seen how the myelin looks like. I mean, if you ask people, we don't know what a actiniurium or like a perinurium looks like actually. So it's the food for thought that we can have these lectures with your permission, and we can have small lectures on muscle and nerve and this thing wherein most of the neurologists will be indicated. And I think I want to highlight to all of you that we are now live streaming all these sessions. So please smile, you're on camera. We are running a bit late, but please smile, you're on camera. This is being live streamed across with a Zoom link to across all neurologists to with us. So this can be done as a Zoom lecture wherein you can take initiative and teach us about.
Now, I say I have to tell the surgeon how it should be taken because neurologists cannot convey to them.
Yeah.
This is a small thing.
Exactly. I mean, how to send a sample itself. I mean, I don't think many people send you now biopsying gluten healthy as ideally it should be, or muscle in normal saline. Exactly. So I think this is a initiative of a new discussion we can carry on from there.
When you cut the muscle, you have to really tighten it. Both ends should be tight with a thread. This side and along this spine, and then there's a wide mistake. We take on that. If you can just cut a muscle, put in any proper mistake, it will shrink
The technology will go away.
Exactly. So there's so many finer things, right? From how to do it and how to send it. So I think we can have this as a Zoom lecture for all of us. Thank you so much, madam. And without wasting much time, I would like to invite Dr. Tejashree. She's the head of radiation oncology at the Siddharth Gupta Memorial Cancer Center in Varda, and she's trained at Tata Memorial Hospital in Uro-oncology. She's been trained in cancer genetics at PMH Mumbai. She is also trained as a senior resident at Tata Memorial Hospital, and I think we will be very pleased to see her inputs on radiation and radiation oncology. And in the interest of time, I would request all speakers to stick to their time. Thank you so much.
Thank you, Dr. Badra, for the kind introduction. Thank you, Nagpur Neuro Society, for this opportunity. So the topic of my talk is radiotherapy for gliomas, basics for neuroclinicians. I will be covering diagnostic molecular differentiation, radiotherapy for low-grade as well as high-grade gliomas, the planning of radiotherapy and its complications. So as we all know, the signs and symptoms of gliomas, I will not delve into it, but if patient gives a short history of symptoms, we have an indication that it could be a high-grade, fast-growing glioma. And if he gives long history, then it can be a low-grade glioma. So do we know the cause of glioma? Not really. The only established risk factor is ionizing radiation. And there are syndromes in which 5% glioma patients can present. So how do we diagnose gliomas? The gold standard investigation is MRI. On T1 images, we see anatomy and areas of contrast enhancement. On T2 and FLAIR, more sensitive for detecting edema. On MR spectroscopy and perfusion, we can differentiate between recurrences and radiation necrosis. This will be covered by Dr. Harsh, but as a radiation oncologist, we tend to see all these things during planning our radiation. So this is how high-grade glioma looks. Irregular masses, necrotic core, peritumoral edema, T2 and FLAIR hyperintensities, T1 hypointense with intense contrast enhancement. And low-grade gliomas, these looks hypointense on T1, non-enhancing, not crossing midline usually, well-circumscribed, solid space-occupying lesions. They are hyperintense on T2 and diffusion not restricted. MR perfusion and spectroscopy may help us in differentiating high-grade glioma versus low-grade glioma. High-grade glioma tend to be more hyperperfusion and increased choline creatinine ratio and decrease N-acetyl aspartate because of neuronal loss due to glioma. Coming to the treatment of glioma, the impact of extent of resection. That as we go to increase the extent of resection, the survival in weeks also increases. Like if the surgeon can remove less than 25% of the tumor, the survival tends to be very low, 31 weeks, and it increases to 93 weeks if they could do a GTR. This is the molecular classification, which has been covered by Madam extensively. So I will not delve into it further. This is the treatment algorithm. Sorry, the font is very small. The oligodendroglioma IDH mutant 1p19q co-deleted WHO grade 2. They typically have good prognosis, and we also see the favorable prognostic factors to decide further adjuvant treatment. So if the age is more than 40 years, there are neurological deficits and residual tumor present, then the patients will typically need adjuvant radiotherapy followed by PCV chemotherapy. If it is grade 3, then they will definitely need radiotherapy followed by PCV chemotherapy. The astrocytomas can be divided into grade 2, grade 3, IDH mutant. The favorable prognostic factors being the same. And if the patients have less favorable prognostic factors, they will undergo radiotherapy followed by temozolomide because of astrocytoma histology. They tend to respond better to temozolomide chemotherapy. Astrocytoma IDH mutant WHO grade 4. Previously, they were named as glioblastoma, but not anymore. But they behave clinically like glioblastomas, and they would require radiotherapy followed by temozolomide, concomitant as well as adjuvant. And after the treatment, we will typically follow these patients every 3 monthly and check for any recurrences or progression. This is the evidence-based standard treatment for the gliomas, which has been nicely covered by Dr. Randive. If the tumor is IDH mutant and WHO grade 2 and the patient has unfavorable risk factors, he will undergo radiotherapy 50 to 54 gray in 28 fractions, followed by PCV or temozolomide chemoradiotherapy. This evidence has come from RTOG 9802 trial, in which 5-year OS overall survival was 72% with chemoradiotherapy versus 63% in radiotherapy alone. If the IDH mutant character is there, then the prognosis is typically good. The median OS is 13 years versus 5 years if the IDH is wild type. In IDH mutant astrocytoma WHO grade 3, the evidence comes from the Catnon trial, in which the concurrent temozolomide doesn't work well, but the adjuvant temozolomide has led to increase in median OS when the temozolomide was given adjuvant setting. In IDH mutant and 1p19q coordinated oligodendrogliomas WHO grade 2, patients with unfavorable risk factors, they will undergo radiotherapy followed by PCV chemotherapy. The evidence again comes from RTOG 9802. Being oligodendroglioma histology, it is itself a good type of tumor, and 5-year OS with radiochemotherapy is 85% versus 80% if we give radiotherapy alone. In IDH mutant and 1p19q coordinated oligodendrogliomas WHO grade 3, patients will definitely undergo radiotherapy followed by PCV chemotherapy. The evidence comes from EORTC 26951 and RTOG 9402. The trials have extensively covered by Dr. Randive, and we have seen that 14-year survival is 25% if radiotherapy plus PCV is combined versus 13% if radiotherapy is given alone. In diffuse midline hemispheric gliomas, the TMZ chemoradiotherapy is indicated, and this data is extrapolated from SCOOP trial, which was conducted for glioblastoma. And 2-year survival rate was found to be 26% with radiotherapy plus temozolomide versus only 10%, half of it, if the RT alone was given. Coming to glioblastoma, IDH wild type, WHO grade 4. In our residency, our professor used to tell us that this is like a death sentence, but still we have to treat it and being optimistic. The favorable prognostic factors being age less than 70 years and KPS more than 70, in which we give temozolomide plus chemoradiotherapy. Unfavorable prognostic factors like if age is less than 70 and KPS is also less than 70, there is an option of hypofractionated radiotherapy, that is the 3 to 4 weeks of radiotherapy instead of the standard 6 weeks of radiotherapy. If there are unfavorable risk prognostic factors, but MGMT promoter is non-methylated, again it is a bad disease and hypofractionated radiotherapy is preferred. If it is KPS less than 50 and a patient is not able to give consent for the treatment, the patient will be planned for palliative treatment alone. What is the evidence of multimodality therapy in GBM? The famous STOOP trial, which was published in NEJM 2005, in which maximum safe resection followed by radiotherapy. Standard radiotherapy 60 gray for 6 weeks, 2 gray per fraction with concomitant temozolomide, followed by 6 cycles of maintenance temozolomide versus radiotherapy alone. In which we have found that patients with KPS more than 60, median OS was 14 months versus 12 months if RT alone was given, and that was significant. And 2-year survival rate was 26% if temozolomide was combined versus 10% if RT was given alone, which was also statistically significant. So this has become the standard of care nowadays in glioblastoma grade 4. Heggie et al. Has done the analysis further, in which they have tested the methylated MGMT promoter regions, and the patients who had this MGMT promoter methylation, they had typically good results with temozolomide with median survival of 18 months versus in unmethylated patients, it was only 2.2 months, which was also clinically statistically significant. Then there are new therapies, tumor treating fields, in which low intensity alternating electric fields delivered by transducer array applied to scalp for antimitotic therapy and given during the maintenance temozolomide. Again, the trial by Stoop et al. Published in JAMA 2017. It improved OS to 20 months if TTF was combined with adjuvant temozolomide versus 16 months if temozolomide was given alone. So these are the outcomes of radiotherapy plus chemotherapy. Now I think you all would like to know how actually radiotherapy works. So radiotherapy works typically by DNA breaks. As we all know, cells divide. The first step is DNA division and then the cellular division. So radiation, typically the high energy X-rays, they do single strand breaks as well as double strand breaks, and which lead to DNA breaks. And if the cell is not able to repair itself, the cell will die. And with radiation, with increasing doses, the maximum number of cells going to die, and that's how we get the response to radiation. So there are multiple ways of cell death that can be apoptosis, mitotic catastrophe, necrosis, senescence, and autophagy. The radiation acts typically in two ways: direct DNA breaks with radiation and indirect DNA damage with free oxygen radicals. So the X-rays, they react with water inside the body, leads to free radical formation, and these heavy free radicals then break the DNA and causes the cell death. Fractionation, like we all know now that radiotherapy dose is 60 gray. Can we give it in single fraction? No, we have to fractionate it and give in 30 fractions, 5 days a week. Why? Because fractionation or dividing the total dose into small daily fraction, it has advantage of differential repair abilities of normal and malignant tissues. The normal tissues are very well able to repair the damage, whereas the malignant cells, they are not able to repair themselves after radiation damage, and that's how they die. So fractionation spares normal tissue through repair and repopulation, while increasing damage to tumor cells through redistribution and reoxygenation. Tumor cells tend to die. Now, the fractionation can be of three types: conventional, hyperfractionation, and hyperfractionation. I have told you before, the patients who do not have who have poor performance status, we tend to give them hypofractionated radiation, means low duration of radiation but high dose per fraction. So in hypofractionation, we give daily ones or alternate days, but the dose per fraction will be higher than 2 gray per fraction as compared to the standard dose, which is 1.8 to 2 gray per fraction. And in hyperfractionation, we give it twice day. The utility of hyperfractionation is very low, in which we give less than 2 gray per fraction. So the standard dose of radiotherapy, that is 60 gray in 30 fractions for the high-grade gliomas, it came from these studies in which the dose response analysis was checked, and it was seen that doses less than 60 gray, they lead to poorer response to radiation, and 60 gray is necessary to have the acceptable tumor control. Then hypofractionated radiotherapy, these are the studies in which they have studied the older patients more than 65 years with poor performance status, and they have compared the standard 60 gray in 30 fraction schedule with 35 gray in 10 fractions, and they have found that there is no significant survival difference between the two arms. Why? Because these patients, the reason of death may not be the tumor, because they have poor performance status and they are old, so they must be having other comorbidities also. So there is no survival benefit. So the hypofractionated regimens can also be used in this subset of patients. So we have seen that even if we give standard therapy, chemoradiation followed by adjuvant chemotherapy, the 5-year survival for glioblastoma is just 10%. So can we increase the dose and can we give 100 gray instead of 60 gray? No, because we have to save the normal brain. It may cause the radiation may cause necrosis of the normal brain. So there are two studies in which they have given SRS boost to a dose of 15 to 24 gray, and they have seen that there is no significant survival difference, but increased toxicities. So doses more than 60 gray are not used in practice. So how do we do target delineation? We see MRIs very keenly and we try to see tumor histology, whether it is benign grade of histology, malignant, I mean the grade 2 versus grade 4, the patterns of failure of that particular grade of tumor, the resolution of neuroimaging and confidence to delineate BTV accurately. Any known anatomical barrier such as falls, tentorium, bone, base of skull is edited from our contours. Well studied and carefully implemented uniform margin generation protocol is in place. So as we all know, we cannot see tumor on CT scan well. So we fuse MRIs with the planning CT scan. But the planning of radiation occurs only on the CT scan because the radiotherapy planning takes into account the Hounsfield unit calculation, which is not possible with MRI. So we fuse MRI with CT scan and then we delineate the tumor on the CT scan. And after our delineation, we give it for planning to the medical physicist. So this is the target delineation in which the GTV, that is the gross tumor volume, is residual enhancing region or gross abnormality in tumor bed, and we give clinical tumor volume, clinical target volume, that is 2 to 3 centimeter margin to include all the abnormality on the T2 and FLAIR sequences. And then we give PTV, that is planning target volume. This is the safety margin that we give because we treat patients for 30 days and there can be movement. So there should not be any geographical miss. So we give planning target volume, that is a safety margin, typically 5 mm. So this, the margin has also come from a study in which they have seen in autopsy specimens. If we give 1 centimeter margin to enhancing tumor, we will cover only 50% of the microscopic tumor. But if we give 3 centimeter around the edema, we may cover 100%. And we always want to cover 100% because we want best results. So the margin is 2 to 3 centimeter around the GTV. These are the radiotherapy techniques. The most basic technique is 2D radiotherapy, in which the simple whole brain radiation we used to do, which is not standard of care anymore. Then comes the 3D conformal radiotherapy, in which the MLCs can take shape of our target and the dose can be conformed to radiotherapy target. Intensity modulated radiotherapy, in which every beam is the intensity of that beam is modulated so that if beam is passing through any critical structure, the dose can be modulated and the constraint for that target, constraint for that organ at risk can be achieved. And the new kid on the block is particle beam therapy, that is protons. So we have given our contour to a medical physicist and he has done a good job by making a plan. So you can see that there are multiple beams which are concentrating the dose towards the target. The red area is the target and the green and blue regions are the low dose areas. So radiation always travels to body and it deposits the dose so that the tumor will get maximum dose and the organ at risk can be saved from the radiation. So there are many normal organ at risk constraints as you can see. So there are a few dose limiting structures such as spinal cord and brainstem in which we cannot cross these constraints. We have to save these organs, otherwise patients will have toxicity. So there are a few dose limiting organs such as brainstem, spinal cord, optic chiasm and retina. And these constraints we have to follow. Then there are few organs only dose limiting if OAR was not part of CTV, that is our target. If it is not a part of CTV, then these doses should be achieved ideally. Then there are few organs such as cochlea and lens. These are not dose limiting, but if contralateral organ is preserved, you can deliver dose there. So this is how we evaluate our plan, in which we see that our target receives the maximum intended dose and our OR should be saved and their dose constraints should be followed. After finalization of plan, the plan is delivered by radiotherapy technologist. So this is the comparison of various radiotherapy techniques. The VMAT, in which there are many angles by which beam comes, and it causes much conformity, better conformity than IMRT plans. And if you can see the IMPT plan, that is the proton plan, in which there are no low dose regions. The brain is completely spared from low dose because the protons have inherent capacity to stop after some depth. Whereas the other techniques in which we use photons, they cannot be stopped. So there will be always dose out of the target. Now, after delivering the fractions, we have to see patients for toxicity. There are acute toxicities and late toxicity. Acute toxicity being the signs of increased intracranial pressure, and we typically give patients low-dose steroids to deal with them. Then there are late toxicities, radionecrosis, vascular lesions, leukoencephalopathy. We have to be very careful about pseudoprogressions, which typically occurs within 3 months of radiochemotherapy. It mimics like tumor recurrence, but it is actually a pseudoprogression, which is the treatment effect. So this is the development of radionecrosis. At the end of 18 months, you can see that the tumor, the radiation effect has settled in and there are no enhancing features. So from 3.5 to 8 months, it is very confusing to know whether it is pseudoprogression or the tumor recurrence. So you have to wait, see patient clinically, give them low-dose steroids and follow them up closely. Thank you very much.
So I think thank you, Dr. Tejushree, for a fantastic lecture. I think we learned a lot of new topics from every speaker. And I think if there are any questions, we can take them from your side. I think this has been a new learning for all of us because there are so many things. I think I did not know what is fractionation. Many people learn that when you say fractionation, how you divide it and why is it important, and the tumor cells die and the normal cells. So a lot of new things that we learned, and thank you very, very much for your talk. I think Harsh has a lot of interesting cases, but I think we don't want to hurry it up. So he's our old friend, so I know he won't mind. And we decided to schedule it at a separate talk next time because we got such a interesting aspects of glioma that we don't want to rush through his cases. So we'll be discussing this radiology at our next meeting. And I think he's a friend, so we can. We'll be very happy for him to detail discuss. Yes, I mean, but I think as a beginning, as a glioma update, I think we have to learn a lot of new. As a neurologist,
just Dr. Tejushree, I mean, is it not really at times that at one level we are fractionating the dose so that there is no damage to the normal tissue because it will get repaired? On the other hand, in radiosurgery, we are giving single dose and too much of a dose. So what differentiates it? Is tight collimetry or what? Because you said radiotherapy. Now, radiotherapy, even radiosurgery is a radiotherapy, isn't it?
Yes, sir.
So, how they are at two ends, they are at loggerheads, these two concepts?
Yes. So the difference is the target. The typical target in which we give fractionated radiotherapy are big, and in SRS the target are small, typically less than 3 centimeters. So in which we make sure that patient doesn't move and we give minimum margins. And then we deliver the high dose in one fraction. So in that, there is the less volume of total brain is going to be irradiated as compared to these big tumors in which we have to give greater margins so that there should not be geographical miss.
So in case the tumor is diffuse and large, You will not do radio surgery.
No, sir.
Linear accelerator.
Linear accelerator is the machine which delivers radiation. It can deliver phototactic as well as the IMRT, but the planning and the margins are different. And the immobilization techniques are also different.
Even the radiosurgery can be fractionated.
Yes, it can be. So the same thing. If the tumor volume is very small, we give single fraction SRS. If it is borderline, like from 2.5 to 3 centimeter, then we fractionate it. The basis of fractionation is to save normal tissues from the radiation injury.
Thanks, Dr. Tejashri, and I would like to congratulate her for setting up the department and has taken our radiation oncology at Savangli to the next level. Thank you so much.
Thank you, sir.
And I would like to thank all the speakers for.
Yeah. So I would like to invite our President, Dr. Lokendra Singh sir, to felicitate all our speakers with the memento and shawl and a small token of appreciation.
We should always include neurologists and neurosurgeons as a team. I find many when
I would invite Dr. Nangra sir, please to join.
there is a neurosurgical topic is there, neurologists would like to go away, and vice versa. It shouldn't be done because we are a team here. And until we support each other, there is no harm in learning each other's science. We have more confidence on our team. And Kavani, thank you very much for being here. You all.
So I would like to invite our chairpersons, Dr. Iratwar sir and Dr. Amrit Bansod. So to felicitate the first speaker, Dr. Dhakogi sir, please, for a fantastic talk. I think even as neurologists, we enjoyed the surgical aspects.
I hope they allow you to take it to Pune. Yeah. It's Aswali is very nearby. So, and I have the pleasure of having Dhakoji with me for many years. 5 years? 5 years. Yes.
Thank you very, very much, sir. So I would like to invite our next speaker, Dr. Makran, who gave us a fantastic insight into the medical aspects of glioma. And I would like to ask Dr. Amrit Bansod to felicitate him. Thank you, Makran, for being here.
I'm sorry I couldn't pick up from your screen. Where you work? I work
I would like to invite Dr. Deshpande, madam. I think she is going to be with us for a very long time because we are going to have a lot of neuropathology lectures and
all those letters have confused. So easy, low grade, high grade. But now these surgeons are lost. Yes, so much.
Hello. Hello.
Thank you so much, madam.
Yeah, I'm going to congratulate.
Thank you.
I'm attending this meeting from 6,000 miles.
So, sir is, I think, in London, in the UK. Yeah, I think he is joining us from.
Have you seen him?
I attended the full meeting.
Yeah.
So, we have.
Congratulations. Dr. Loken, Sandeep, everyone, everything. It's fine.
Yeah.
Very good.
So it's a global.
It's a global event. Don't take it to be a local event. It's a global event. People are joining in from London, UK also. The ex-president of NNS is joining in from the UK. So I think this is a good thing. A lot of people from Vidarbh, Yavatmal and Yakola, Amravati would love to join this. So I'd like to invite our next speaker, Dr. Tejashree. And she gave a fantastic insight into, I think we don't know much about radiation, but we're very happy to learn certain new concepts of how to deal with. So we have Sham sir, I think on the screen joining from London. I think all of you can say hi to him. Thank you so much. Thank you so much for. And I think the loudest round of applause should be for Harsh, who made it here. But I think he had such fantastic cases that I really and all of us discussed that they should please join us because तुम लोगों को ये जो प्री लॉन्च होता है ना प्री वेडिंग so this is a pre-launch of Harsh talk that उसका सर में
And next time we will take the whole juice out. Radiology.
So I think that this is Harsh has fantastic cases. I think this is sort of a teaser or trailer for all of you to not miss the next meeting because he has fantastic cases about glioma, pseudoglioma, false progression, true progression, and all the differential diagnoses of all the MRIs where you can miss a glioma and it turns out to be you think it is autoimmune encephalitis, it is a glioma, you think it is glioma, it is something else. So it's fantastic collection and I think you got the best applause for not delivering it all. Yeah, but Harsh is a very dear friend and I think we can request him to do whatever we want. He is a very good friend and I think I take liberty to all the neuroscientists. So thank you so much for being here.
Very sharp and fast and smart radiologist to diagnose my stroke hand.
So we'll definitely have Harsh with us for the next meeting. Unfortunately, due to constraints of time, we could not do this, but this is definitely next time. So thank you very, very much, everybody, for joining us. And please, we'll. And outside, I would like to thank Vinisha and Disha and Medronics for making this event happen and to the grand level. I would like to congratulate Dr. Singh sir, Drew, for the very first theory, and that was a super successful conference. So I would like to call Paltevar sir, Paltevar sir, please. I would like to call you to felicitate our chairpersons. Did a fantastic job of holding the meeting together, holding a meeting together, and speaking to and Dr. Amrit Bansal, my dear friend and colleague, so you might be say called as a chairperson. Thank you so much. Thank you.
Congratulations, everybody. Congrats.
Thank you very much for
Nagpur Neuro Society team. Congrats. Very good seminar.
One more thing. This is a ceremony presentation of. Yeah. Dr. Lokendra Singh has become a president-elect of MCNS. That's a Midwest chapter of neurological surgeons. So he's going to. No, this is MCNS. So we'll have to make such thing called Nagpur Neuro Society also.
I think we have to make it. Yeah. I just forgot to make it. Thank you, brought it.
I told you I'll give it on this. I think.
It's a life. So, what time and just
I see many. Sir, Babulkar sir, we can make an announcement for the membership from London.
Sir, you unmute yourself. You are muted. You are muted. बरोबर सर तुम्ही अनम्यूट करा muted आहे तुम्ही muted आहे okay on behalf of sir is there okay on behalf of Nagpur Neuro Society I think those are the members registered him as a member of Nagpur Neuro Society कुछ अनाउंसमेंट करना है तो कर दो